I developed a theory, and I call it the architectural tonic. And it's been a great tool for me. And when I started that improvisation, I started on D. And that whole music I played was anchored to D. And that often is a great way to have an architectural tonic for a session, because it doesn't mean then you're getting into formed modulations. And I always joke with students that it sort of sits over the top of my head, that note is something that everything comes back to. And it's been a great tool for me, my improvising. So a tonic note might come from my perceptions of the client. I worked with a client who would always come down the corridor singing around an E flat or an E. So he would, through his humming, he would dictate the architectural tonic. So the best architectural tonics come from the client. Or the client might come in and hit a note. It's an A. Then you would make that your architectural tonic. I believe really firmly that when you're with a client in therapy, that you have to produce the finest music you can for that client. And anything other than that is to fail. So I'm sort of stating a nirvana sort of situation, but if a client comes in and makes a sound, the sound that I make in response to that is ultimate. So it may be one note, it then may be an interval. It may be a simple phrase, it may be a harmonic progression, but that every note that I play in response to the client has to have some intent and meaning. There was a guy who'd had an operation, he was completely passive and blank, and he looked really ill, and so what I would do I improvised for him, and he didn't really move. I gave him an instrument, but as I looked, and what I try and do, I talked earlier about moving myself back. If I'm playing music from a client, I try and put myself back so that the music will really speak to him. And he sat there, and all these drops came down his eyes. And I have many experiences of that, because for me, spirituality is about something that I cannot know, that the spiritual connections with music are beyond my knowing of that. And it doesn't necessarily speak to God, but it speaks to the power of music to move people in inextricably profound ways that I can't always know. And in palliative care, it was on a daily basis. It was on a daily basis that I would experience. And again, the spirituality in music is the non-verbal part, is the fact the music is able to reach, touch, be inside that person at a place where I may not know what it is, but the manifestations are so clear. And it became concrete for me. Spirituality in music was not an esoteric process. It was always really concrete. It's about God because it's about something bigger than who I am. I see God, or whatever name you might give that, as something that is bigger than myself. And so the music was God. And I was, in a way, the person that was the vessel to try and get them to that place, however that may be for them. And that's why I really take the job of the music therapist. I think music therapists should use music with the greatest caution. You know, we really need to think about the music that we give clients, because we have this potential to allow them to have these profound, godlike experiences through music. And we're the tools to do that. And it's kind of scary.
It makes you a little priest-like.
Yes, I hope not, but I worked with a young man in his 20s that was dying, and I had this sounding bowl, and I went with a physiotherapist, and we did these relaxation sessions, and we would go in the last couple of days of his life 3 times a day, and I would put the bowl on him, and because he was so racked with pain, and I remember he was the day before he died, and he suddenly opened his eyes and he went, it's also enlightened. What the physiotherapist said after that, this was the one time when he wasn't grounded. You know, when you're ill, you're racked with pain, pain grounds you. We were able to give him that experience of flying, of not being grounded to his immediate, which is why I think he said it. Yeah. Well, and I think for me the extraordinary thing, because I teach full time and I use case studies or stories. Like, I don't have any of the recordings of the guy that I just spoke to you about, but when I teach from them, and I teach from them every day, I remember exactly everything. I can see the room, I can see who was there, I can almost smell the smells, I can see the window, I could describe to it accurately. And that experience I told you, it must have been 25, 20 years ago. And yet I can remember it as clear as if it was yesterday. And I talk about it a lot at work and play examples, and it's quite hard. Sometimes I just try and cut myself away from it because the memories of it are painful. I mean, so I think in going back to the spirituality thing, you know, being a priest and all that, actually I didn't always want to do it because actually it hurt and it was painful. It wasn't like, ooh, there's this spiritual experience, aren't I being wonderful, I'm a great therapist. Actually, it was really not easy. And I didn't always want to do it. It was my job, and, you know, I knew I had to fulfill my job, but I didn't like it. But, I mean, musician first. I remember I used to go into the hospice, and the hospice I worked at was in a hospital, and some days I go, how did I get here? You know, I'm trained as a musician. What am I doing in the middle of this hospital? It was really weird. Teaching clinical improvisation is a very matter-of-fact science, and from the way I teach it, and I was trained in the Northrop-Robbins approach, which actually has a very clear pedagogy. So at Laurier I have a very clear pedagogy, and it starts with going back to the fundamentals of the tone, and then the interval. And then, as I said before, one of the things students find most hard is they have to be able to improvise an A theme, and repeat it, and then a B phrase, and repeat it, and then repeat the A phrase. And it sounds very simple, but I've had lots of students crying, and like, I can't do it. So I think learning to improvise clinically is a science. You know, going through the modes, it's really going back to what is music, you know, and the building blocks of music. And I was a musician before I went into therapy, but it's like when I did the Northrop-Robbins training, it took me right back to square one, and I dismantled everything I knew about music, and then I rebuilt it again in a clinical setting. So there's 2 years at the graduate level, 3 hours a week, where this phenomena of clinical musicianship is taught. And you have to practice, and then, you know, you have to come in and then play, because what happens is students need to learn the conscious ability to play music and all the idioms and the different styles, so that when they get in the session, they can put it to the back of the head.